Welcome to this show discussing problems and issues of health with Dr. Alcena. I'd like to say Happy New Year to everyone. This is the 28th year of the show, and I want also to start talking about diabetic ketoacidosis as well as non-ketotic hyperosmolar coma. These are the two subjects that's left to talk about in terms of this long series that I've been doing on diabetes. Diabetic ketoacidosis is a very dangerous and common problem. Every year, more than 200,000 folks get admitted to the hospital every year in this country because of diabetic ketoacidosis. They want to know, what is this all about? What is diabetic ketoacidosis? What it is that the physiological problems, mechanism, I should say, is the fact that when one is under stress, the stress can be brought in usually by an infection, such as pneumonia, urinary tract infection, etc. And someone can have a heart attack, and stress associated with alcohol abuse and this kind of stuff. That then can cause the level of adrenaline and cortisol to go up. When those things goes up, several hormones that's going to become elevated are usually associated with, those are anti-insulin hormone. The anti-insulin hormone, such as adrenaline is an anti-insulin hormone. It negates the effect of insulin. So the insulin cannot be present in order to prevent the sugar from to be able to use, because it knocks it down. So it is very important that you understand the mechanism, really. This is really what happens. The other problem that can happen is that some people simply get to a point where they can't afford the insulin. The insulin is now becoming very expensive. Some people are paying $450 a month to buy insulin. That is a lot of money. A lot of money. So therefore, some folks miss their dose of insulin, and the sugar then goes out of control, and then they don't realize that they're having the symptoms that are associated with this insulin problem. Before you know it, the blood sugar goes up to the 300. The diabetic ketoacidosis, the sugar is usually in the range of 300 to 500, in that range. When that happens, the body needs energy. So the body then started using ketone fat for energy. But fat is an awful form of energy, very bad form, because the breakdown product of the fat are ketone bodies. The ketone bodies accumulate in the bloodstream, and then the person then develops the different symptoms of diabetic ketoacidosis, which can be excessive thirst, frequent urination, nausea and vomiting, abdominal pain, weakness or fatigue, shortness of breath, a fruity smell in the breath, and of course that can ultimately lead to confusion. The confusion then can lead to coma. So it is crucial that the treating physician, first of all, the individual who was sick, seek medical help quickly, assuming that they're in a position to feel how sick they are. Because sometimes they become so confused, they don't know why they're confused until they wind up in the emergency room, and the physicians that are taking care of them, they will do the appropriate tests, and they found that, oh my God, this is diabetic ketoacidosis. Very, very dangerous situation, and I'm going to explain to you why it is so dangerous. It is dangerous because all these ketone bodies piled up in the bloodstream, and when the urine is tested, it is positive for large quantities of ketone bodies. When the blood test, that is the chemistry profile, is done, they found the blood sugar to become elevated, but as part of that, they also find the patient is very acidotic. What's interesting about that, God created the human body to be able to tolerate acidosis more so than alkalosis. So people can be acidotic for a long time, don't realize how sick they are. And then the acidosis along with it, the serum potassium shoot right up. And a very high serum potassium can be very lethal to the heart. So once the patient is examined, the chemistry profile is done, the urine is tested, and they found this severe level of acidosis, hyperkalemia. The electrolytes are completely out of whack. And then, of course, comes the most important aspect of this. This is, of course, the history and the diagnosis. You do the physical exam, and then you have to begin the treatment. The treatment must be started quickly. This is one of those diagnoses. There are many, many diagnoses in the field of medicine that just simply cannot be missed or cannot be delayed. This is a diagnosis that must be made promptly, and then treatment must be started immediately. Otherwise, you're going to wind up losing the patient. The death rate in diabetic ketoacidosis is also very high because frequently people present very late, too late. Okay, so now that you get all this stuff done, you did the chest x-ray to look for pneumonia, you took out the urine to look for infection. You didn't find any infection, but you find ketone bodies in it. You did the blood gas, you did the electrolyte. It's clearly the patient is very acidotic. Then you have to quickly get involved to treat the patient. The most crucial treatment in this setting is going to be intravenous insulin, regular insulin. You need regular insulin. It has to be given intravenous. You say, how come? Well, the patient is so sick, they may be hypotensive. They may not be perfusing very well. You can't take a chance to put the insulin subcutaneously because you're not sure if it's going to get in through the bloodstream because of the blood pressure is low, the perfusion is poor. However, by put in a pump, you load the patients up with 20 units of regular insulin acutely. You set up a pump, give them normal saline to hydrate them, and the insulin also, since the potassium is high and the patient is very acidotic, you're going to give the patient bicarbonate. An acute tube of bicarbonate is given acutely, 1 amp acutely, and then after that you could put the bicarbonate into the IV itself to bring the level of acidosis down. Crucial. What's fascinating about that, now you have sugar that is very high, between 300 and 400. You spend the first day giving this patient insulin and normal saline with bicarbonate in it, etc., doing all the other stuff. If the blood gas is bad, the patient cannot breathe properly, give them oxygen, whatever. If the patient has pneumonia, clearly you're going to do blood culture, try to get sputum if they cough, if they can't cough, and you're going to start treating the infection, whatever the infection is. Do the blood culture, the urine culture, that goes without saying. And you must know exactly what type of antibiotic to give. But even though the result is not back yet, you must know enough about clinical medicine to use the broad spectrum antibiotic that cannot miss. You absolutely cannot miss this infection. So you must use enough brain power to cover the patient broadly so that gram-positive will be covered, gram-negative will be covered, anaerobes will be covered, so that you cannot miss. You don't have an hour, you don't have a minute to miss. You can't miss that. Now the patient is covered. If you identify the infection, now you have to manage the diabetic ketoacidosis. The way you manage that is IV fluid, particularly normal saline or half normal saline, depending if the patient has an underlying cardiac problem or if the patient, you have to know any form of stress can cause the person to develop diabetic ketoacidosis. Because when you're under stress, it could be mental stress, Could be work-related stress, could be stress associated with an infection, stress due to a heart attack, pneumonia, or whatever. Your adrenaline level is going to go up, your cortisol is going to go up. And both of these things are anti-insulin. They negate the efficacy of the insulin. Okay? So you have to do what you can to bring the stress situation down so that the level of adrenaline comes down, the cortisol comes down, the insulin that you're given is not going to work. What's fascinating about this, the first day, you're doing all you can to stay away from sugar because you want to push insulin as much. The very next day, the absolute very next day, you can't make this up, the very next day you must quickly change the IV fluid to have sugar in it. That's right. How about that? The first day, you can't touch sugar. You're trying all you can to bring the sugar down to insulin. The very next day, you have to change the IV fluid now with IV fluid that has sugar. How about that? You say, well, what are you talking about? Well, let me tell you something. You can't survive without sugar. Or you can't do it very long. And when you're that sick, the patient is catabolic, destroying tissues, catabolic. You want to bring your patient into an anabolic state. And the best way to bring your patient in an anabolic state, especially if the patient cannot eat because they're still very sick, you must now switch the IV to a fluid that has sugar in it and the insulin. So the insulin, the sugar that is now in the IV the next day, with your electrolyte, all this fancy stuff being taken care of, the insulin is going to push the sugar through the cells so that your patient can now become anabolic. Let me repeat that. Don't be afraid just because the patient sugar was very high yesterday and the next day the patient still cannot eat and you're afraid of sugar. Oh no, you must change the IV fluid. Let me repeat that. You must change the IV fluid to one that has sugar. Either normal saline with sugar, half normal saline with sugar, and if the potassium is down, now you have to stay away from bicarb. How about that? Yesterday you wanted to bring the potassium down. Now you got to be very careful with potassium. Why? Because insulin is going to bring the potassium down. How about that? The same insulin that you need so badly, that you were worried so much about yesterday, now you must then try to watch the potassium closely, because as you're giving the patient the bicarbonate, you're also giving the patient the insulin. Insulin brings potassium down. One of the acute ways to bring potassium down is to give the patient insulin and bicarb and sugar. Somebody's have acute potassium elevation for whatever the reason. The quickest way to do it is sugar, insulin, and bicarb. Okay, so everything changes the next day. You must spend the whole night at the bedside. Make sure you're doing that. Now your patient is no longer ketotic, but now he or she all of a sudden needs sugar and insulin. And that's the way you do it. And now you resolve the acute situation. If there's an infection, you treat it. If there's a heart attack, you treat it. All these things that can cause the stress to become an issue, you treat all those things. Especially now we're talking about, we're living in an era now people are getting overdosed with all this opioid that's going on. Cocaine abuse, similar to alcohol abuse, can also bring diabetic ketoacidosis on. So you would have tested the patient, urine for drug, blood for drug. You would have done all that. When you can't forget these things. That's right. And unfortunately, the saddest thing about it, we now live in an environment where the patient only issue may be she just couldn't afford the insulin. She started to ration it, and she overstepped the rationing too much, and she developed diabetic ketoacidosis because she doesn't have the money. $450 a month to buy a supply of insulin. This is outrageous. And as we begin this new year, all the drug companies I read yesterday have raised the price of medication by 5%. We have a lot of folks with no insurance. But also with insurance that doesn't have a good medication part to it. And they have to pay rent. They have to pay mortgage. They have to buy food for themselves and their kids. They have to buy clothes. They have to buy the coat for the winter. They have to do all the usual stuff, gas for the car. And then they have to come up for $450 to buy insulin. When I trained, insulin was cheap. I mean, really one of the cheapest things you could buy by way of medicine in the early 70s and mid 80s was insulin. Now, I checked it online yesterday, $450 per month. That is outrageous. So this is why poverty in this rich country is leading to people's life to be endangered. The poorer you are, the sooner you're going to die. The richer you are, the longer you're going to live. In particular, if you're rich and you're not arrogant, you find yourself a good primary care doctor that's going to take care of you. Not the limousine type. The limousine type usually is just that, limousine type. When you're looking for the best doctor you put your hands on, you don't look for somebody who's driving a limousine. That's a different type of medicine. I just read a few days ago. This is going to shock you. Of the $3.2 trillion, 3.2 is going to go to 3.5 this year, I heard. So they did a massive study. Listen to this, massive study that concluded last year, a couple of days ago. I read it. $935 billion, $935 billion are wasted every year in this country doing unnecessary tests and unnecessary lot of other stuff. 935 billion being thrown away. People who don't know what they're talking about, but they want, all of them want to get into the, you have to understand, besides the military complex, the healthcare system, in fact, it's already past the military complex, is where has the most money, is the healthcare system. So everybody who don't know what they're talking about want a piece of the pie. They set up all kind of bogus companies, bogus ideas, bogus stuff, and they force themselves into having people accept it, and they force it on us. I have an outfit whose name I won't mention. Out of the blue, several years ago, gets set up with every 90 days. You can't make this up. Every 90 days, all licensed physicians, all licensed dentists, all licensed PAs and experts, whatever, must be re-attest or whatever every 90 days. What could you possibly have changed in 90 days? When you apply to a medical staff, it's every 2 years you get reappointed. These folks track every little thing about you. Your life is in the open. And then it's a new outfit. And they find a way to marry themselves with some fancy HMO companies that agree with that stuff. I mean, can you imagine that, as busy as doctors are? Every 90 days, we got an email. We have to reattest who we are, answer all the silly questions all over again. There's very same question that we have to answer on this long, I get reappointed at Montefiore. You don't want to see the package, huge package that you have to put out form by form by form by form by form. And then on top of that, Montefiore make you go online. The other day I spent more than 2 hours as someone who's not good with the computer taking an exam online. And then I have more exam to take. That's not enough. These people set this thing up. They're making millions of dollars in new company. Then I got other companies trying to get patient medical record because a patient has some co-payment with them, and they need to get 4 or 5 years of record every so often. Who are these people? These people don't know anything about medicine. If the doctors were doing something improper, they don't know how they're going to discover that. They don't know about, they think they do, but they really don't. But it's a company. It's a money-making outfit. That's where the $935 billion, that's where some of it is going. Doctors who have good judgment, and heaven knows there are many of those who have excellent judgment. We have knowledge, experience, and judgment. You have to have all these things in place to practice clinical medicine. You just order silly, expensive, outrageous tests, like the test is going to practice for you. No, it doesn't work like that. But that's what's going on. $935 billion being thrown away. Forget about the necessary. This is all, this outfit, this is all unnecessary stuff. And now they'll go ahead now, raising the whole thing again by, what do you call that? 5%, the drug companies. It makes no sense. In any event, that's the story. That's how it goes. There's nothing we could do about it. We have to just live with it. That's the United States of America. That's our country. Great country. But we have all these issues to deal with. So diabetic ketoacidosis is a major problem. I'll be talking more about it. I'm not done yet. And when I'm done with diabetic ketoacidosis, I will then be talking more about non-ketotic hyperosmolar coma. That's another form of people going into coma. And also the whole issue of another crisis that can exist, the diabetic film, which is, of course, hypoglycemia. I'll be talking about all that stuff. So this is the reality that we have to deal with. Serious business. Listen, I'm going to stop here until I see you guys again. This is Dr. Alcena saying so long and bye-bye.